Today we'll be talking about the basic principles of the musculoskeletal system as it applies to underwriting and claims in the insurance industry. I'm going to break the session down in basic anatomy, the function of the musculoskeletal system, and also some important pathological conditions. Let's start with anatomy. The basic anatomy of the upper limb, we start with the clavicle, which is the collarbone, then the scapula, which is the wing bone at the back of the shoulder. The main bone in the upper arm is the humerus, and in your forearm you have two bones, the radius and the ulna. They are crossed over each other, and that allows for supination and pronation of the forearm. In the hand, we have the carpal bones, that's the wrist bones, as well as the metacarpal bones, those are the hand bones, and then the finger bones, the phalanges. The joints between the phalanges are called the interphalangeal joints, and there we have the proximal, closer to the hand, and distal, the closer to the fingernails. So distal interphalangeal joint, abbreviated as DIP, and PIP, proximal interphalangeal joint. Around the elbow, we have important prominent points, the medial epicondyle and the lateral epicondyle. Those are the distal bones of the humerus, also your funny bones, because the nerves run just behind those bones. So if you do bump them, you do have that painful sensation. Let's move down to the lower limb. Here the lower limb starts with the base as the pelvis, and from the pelvis we have the thigh bone, the femur. The femur is also a socket and ball joint, where the socket is the acetabulum and the ball is the head of the femur. So together they intertwine and form the joint. The femur has a neck and then a long shaft, moving down to the knee. The distal end of the femur also has the lateral and medial epicondyle, and the femur articulates with the tibia. It's the large shin bone. We also have a fibula, a smaller, thinner bone on the outside of the lower leg. The patella is the kneecap. Around the ankle joint, the fibula and tibia ends in the ankle bones, which are again the lateral and medial malleoli. I just want to mention two of the important foot bones. First, the talus, which articulates with the tibia, and then the heel bone, which is the calcaneus. Then we also have other smaller foot bones. We don't have enough time to discuss all the muscles, but the flesh on the bones are obviously the muscles, and they do end in ligaments that attach to the bony structures. I want to use the calf muscle as an example, where two calf muscles, the gastrocnemius and the soleus, do attach to form the longest and strongest tendon, namely the Achilles tendon in the body, and that attached to the heel bone, the calcaneus. That concludes the basic anatomy. The functional range of movements of the musculoskeletal system is important. Some functional considerations that we need to consider in assessing any joint is firstly to look at the pain around the joint, the stability of the joint, the range of movement, muscle strength, as well as coordination, which is obviously important for coordinated movements. Usually, if coordination is a problem, there is some nerve involvement. Muscle strength is measured in a grading system. I want to discuss the grading system briefly because these we do see in reports often. A grade 0 is when there's no muscle contraction at all. Grade 1 is where there is a flicker of movement in the muscle, but it doesn't move the joint. Grade 2 is movement at the joint when gravity is eliminated. So, for example, when you just move your limb in a horizontal plane. A grade 3 movement is when there is movement against gravity, but with no resistance. So you can lift your hand up, but you can't pick anything up because that would be some form of resistance. Grade 4 movement is when there is movement against gravity and with some resistance. So for example, you will be able to pick up a light object. And grade 5 muscle strength is normal muscle strength against resistance and being able to pick up objects. Looking at the function of the shoulder as an example, the shoulder is important to allow us to reach for objects and also to lift objects up. Therefore, we need strength around the muscle as well as good stability. And these are the principles you must remember for each muscle group. In the hand, our thumb accounts for 40% of the hand's function. And illustrating this, it will show in the types of grip we apply. A cylindrical grip, for example, when you hold a glass of water. A fist grip, for example, holding a racket. Or a spherical grip, when you hold a ball or an orange, as an example. Precision grip between the index finger and the thumb is important. Again, for a tripod grip, holding a pen, a pincher grip, holding something fine like a needle, or a lateral or key pinch when you hold a deck of cards or your map when you are traveling. The functional range of movement of the knee. I want to use as an example to show what a normal range of movement will be, but then also compare it with a functional range of movement and understanding how it affects our abilities. The normal range of movement is 135 degrees flexion of the knee and 0 extension of the knee. So you need 90 degrees of flexion to be able to sit and stand up comfortably from a chair without resorting to awkward maneuvers. You need 80% of flexion in your knee to be able to climb a stair and 117 degrees to tie a shoelace or pull on a sock. Obviously, it also requires some hip flexion and forward flexion of the lower spine. So this shows that less than normal can still be functional. And this principle applies to every joint. In the last section, I want to discuss some pathology found in the musculoskeletal system. And we will start with injuries as these are the most common. Now, important considerations are the mechanism of injury. This will give you an indication what type of force was applied and what the outcome of the injury would be. Will it be direct hit to enable a fracture or a twist that will lead to ligament or cartilage damage? Contamination during an injury is very important because this will also imply the type of complications that could be found and the need for aggressive antibiotic treatment or surgery to rinse out the wound. If this is accompanied with an open fracture, the risk of chronic infection or osteomyelitis increases. When there is intra-articular fractures, a fracture that goes through the joint, or infection, the risk of future osteoarthritis is very high. We must also remember potential damage to structures around a joint, as there are nerves and blood supply that run across bones or joints that can be damaged. Here I want to use the example of the elbow. If we have, for example, a supracondylar fracture, that is a fracture just above the elbow joint in the distal part of the humerus. Across the elbow, we do have the brachial artery as well as the median nerve that runs in the middle of the elbow. And then the ulnar nerve runs just medial or at the back of the medial epicondyle. When we have a supracondylar fracture, there will be sharp bony ends, and these sharp bony ends has the potential to nick or sever the brachial artery, or even just the swelling around the joint due to the injury can lead to constriction of the blood vessels. This leads to ischemia, reduced blood supply to the distal end of the arm, and this can end in injury A most common one is a Faulkner's contracture. This is a flexion contracture in the wrist. It has a very poor prognosis and can set in a short space of time. When we look at the hip, to use it as an example for dislocation injuries, I'm going to use the hip to illustrate dislocation injury. If the hip is dislocated and the ball and socket joint is out of position, there is stretching of all the elements around that joint, including the nerves, the ligaments, but most importantly, the blood supply. A dislocated hip is a medical emergency, and people do need to have that hip reduced within 6 to 8 hours' time. After that, the risk of that lack of blood supply becomes very high to cause permanent damage and gradual avascular necrosis to the hip joint. Avascular necrosis eventually leads to osteoarthritis, where we will find thinning of the cartilage and thickening of the bone just below the joint lining with an uneven joint. Moving on to ligament injuries. I want to use the ankle as an example. A sprain is graded into 3 grades. A grade 1 sprain is where there is stretching of the ligament with maybe small tears. A grade 2 sprain is a larger but incomplete tear in the ligament, where a grade 3 sprain is a complete tear through the ligament. In ankle injuries, an inversion mechanism, that's where the ankle joint inverts, that is the mechanism that leads to stretching or spraining of the ligament. Coming back to the Achilles tendon, this can rupture as well. And then, with a full rupture of the Achilles joint, you will not be able to plantar flex. That means point your toes downwards. You won't have any strength to be able to stand on your toes, climb stairs, or to jump, as an example. The importance of fractures is that they can alter the anatomy of that limb. If a fracture leads to overlap, it can lead to a shorter limb, but this can be corrected with surgery. For example, in the femur, they can place an internal fixation through the femoral shaft. Tibial plateau fracture is an important example of a fracture through a joint. And this can lead to a lot of bleeding and swelling in the knee joint, and then the future risk of osteoarthritis increases. This brings us to the pathology of osteoarthritis. The common joints that are affected is the hands, knees, hips, shoulders, and the base of the big toe. The pathology found in osteoarthritis is degeneration of all the elements of a joint. Firstly, we find thinning of the cartilage, then narrowing of the joint space, thickening of the bone underneath the cartilage, then bony spurs or osteophytes develop. Due to this additional bone growth, there is stretching of the joint capsule with swelling, and then synovitis or inflammation around the joint starts to develop, and then the whole integrity of the joint is weakened, so the muscles around the joint as well. The clinical presentation of osteoarthritis starts initially with a short duration of joint stiffness, up to a maximum of 30 minutes in the morning. Then pain around the joint, that firstly starts when doing activity, for example, when climbing stairs, but then gradually it increases during the day to be intermittently present, to be finally continuous. Then you find continuous stiffness of the affected joint, a limitation in the range of movement of that joint, and then the swelling and deformities. There is no specific blood test to diagnose osteoarthritis. It is taking a history and looking at the clinical picture and the examination of the joint together with the X-ray findings. The classical radiographic findings of osteoarthritis is subchondral cyst formation, new bone formation around the joint lining, that's the osteophytes, sclerosis of bone, that is thickening of the thin area just below the joint space, and then joint space narrowing. The treatment of osteoarthritis starts with non-steroidal anti-inflammatory drugs, typical ibuprofen and diclofenac. Exercise and physiotherapy remains important, and intra-articular cortisone injections may be helpful. These are reasonable therapy to expect patients to undergo. Joint replacement surgery cannot be enforced, but obviously would help to manage pain and improve functionality around a joint. This is an example of a total knee replacement, but sometimes only a partial knee replacement might be needed. This concludes the introduction to the musculoskeletal system, and I trust this has helped to whet your appetite to understand the body system, and when you study it in more detail, to apply the functional aspects of the anatomy and the joint movement, and to apply it to insurance medicine, both in underwriting and claims assessment.